internationally like Dr. Jens Chapman. Dr. Locke is going to introduce Dr. Chapman in a second, but I want to spend just a few minutes talking about Dr. Chan in this lectureship. I think the lectureships we have here are really important because it helps bring people in to talk about what we're doing here, but we also get to learn a lot from them about what they're doing at their institution. So it's a great exchange of understanding. Dr. Chan did his training in the 60s up at the University of Hong Kong. And as you guys know, in the 60s, tuberculosis TB was a big problem. And it wasn't just medically difficult to treat, it was also surgically because TB causes a lot of spinal deformity. And they created the Hong Kong operation, and what that was is you do a thoracoabdominal approach to take a section of your rib and fuse the spine anteriorly. So it really gave you an understanding of what the importance of anterior column support was. But I think it really was a precursor to what a lot of us here are doing, Dr. Lee and Dr. Locke, with sort of the anterior and lateral approaches. He subsequently went on in the 1970s to the University of Rochester, where he was the professor and division head of spine there, and we were fortunate enough to recruit Dr. Chan here in 1994 to be the division head here. When he was the division head here, he started the fellowship, the spine fellowship, and he trained over 30 spine fellows here nationally, internationally, and he was instrumental to sort of being a mentor and bringing me back here to be young faculty. So that was, you can see a lot of what I do through his mentorship. He retired in 2006. He's now emeritus, but during his career, he was the SRS Scoliosis Research Traveling Fellow in 1971. It's a big honor to be a Scoliosis Traveling Fellow, but he was elected again in 2005 to be the Senior Traveling Fellow. So it really speaks to how impactful Dr. Chan was in society to be a Traveling Fellow twice. He became the past president of the SRS, and obviously in 2021, he received the Lifetime Achievement Award. So it really has been influential, not just here, but also in the field of spine. His lectureship was supported through his residents, his fellows, and his grateful patients. So that's allowed us to, in perpetuity, bring people like Jens Chapman here, who is a good friend and colleague to this division, and to me personally as a mentor as well. Dr. Locke has spent some time with Dr. Chapman, and I'm going to have him come up and sort of introduce Dr. Chapman. I look forward to your talks, especially the second one.
Thank you, Dr. Chapman. Morning, everyone. I have the honor of introducing our visiting professor today, Dr. Jens Chapman, a man who truly does not need an introduction. His contributions in terms of research, education, and leadership in the field of spine surgery are simply unmatched. And the impact that he's had on the way countless surgeons, including myself, practice across the nation and world, for that matter, is also unmatched. He completed his medical degree in Munich, Germany, and his residency in orthopedic surgery at the University of Texas, and ultimately went on to do a spine surgery fellowship at the University of Washington at Harborview, where he ultimately became chair and had the distinct and very rare honor of serving, having dual professorships both in the Department of Orthopedic Surgery and the Department of Neurologic Surgery. He is now at the Swedish Neuroscience Institute across the street in Seattle. Dr. Chapman has published hundreds of scientific articles and textbook chapters spanning from deformity correction to spine biomechanics and rehabilitation. His work has influenced practice standards, instrument design, outcome metrics, and the division and the delivery of spine care globally. On a personal note, I had the privilege of spending 2 weeks with Jens when I was the North American Spine Society Traveling Fellow, and spent 2 weeks out in Seattle. And Jens, I can say that without question, those 2 weeks were as impactful as any time that I spent in training. And I want to thank you very much for that. And in fact, Jens doesn't know this, but his influence on my education started well before we met. My wife can tell you she recognizes Dr. Chapman's voice from falling asleep to his lectures through the Seattle Science Foundation when I was early on in residency. Dr. Chapman, thank you for your impact in our field and the time you've taken to be with us out of your busy schedule. And with that, I'll turn it over to our guest speaker.
Thank you. Thank you for the kind words. So I'm Jens Chapman. It's a great honor to be here from Seattle, Washington. And I know all the words are very touching. I'm not crying. I had eye surgery, and so I'm kind of blurry-eyed from that. So just wanted to give an explanation for why I'm kind of blurry-eyed. Who here is a spine surgeon or considers themselves a spine surgeon? Okay, and who is interested in spine? Everybody. Great. Okay. Any neurosurgeons here? I've been here before with neurosurgery twice, so this is my first time here, but I'm an orthopedic surgeon by main designation, so I'm really proud Very honored to be here. These are my interpretations of trying to match the orange of the University of Virginia. This was in the fall leaves. So I was walking around the campus yesterday. So if you wonder why I'm putting fall leaves up, I was trying to find the right color, and I was just educated. It is Cavalier orange. Did you know that's Cavalier orange? Your V is Cavalier orange. So fuse or not to fuse, that's the subject. And again, I really hope to interest all of you in terms of the spine. I know spinology is its own section and it's so easy to get siloed, but the spine, remember, that connects everything. And I always have believed in the integrative power of the spine. So hopefully this will not be too boring for you. I want to point out that I have two significant conflicts of interest with two companies, and I'll point those out later. Arrogant declaration. I believe we can change lives. All of you can change lives in musculoskeletal medicine. In spine, this is, again, a 14th century woman. The spine can create more misery than anything else if left unchecked. And this is not a bravado lecture, it's probably an anti-bravado lecture, but I love doing these procedures. And again, we can change lives. This is a positively changed lives just by realigning the spine. Here's a catchword: encephalization. What's encephalization? Anybody? Encephalization is why our brains can be so big. Why we as human beings succeeded as mammalians is because we can have a brain vertically over our pelvis, over our foot and ankle. Didn't know that, did you? Encephalization. So the spine serves our encephalization purpose. Am I losing it totally, Dr. Lito? What is he doing? No. But so by having this skull vertically over the pelvis again, in alignment, as they say, that's a big deal. And that's what a healthy spine should be able to do. Buzzwords in our field are obviously these here. And again, everybody talks about AI, and I'm not talking about that, but one of the main things has been in our field, minimally invasive surgery. And this is, again, just a big, big deal, but these are our buzzwords. All of those are associated with great promise, great cost, and not always totally clear benefits. And that's the point. So, personal disclosure, and I'll end with the disclosure in a second. There's one more disclosure slide after this. I have three things as my Germanic background. I can't help it. I like precision. I like efficiency. I don't like to terrorize anybody. It could be a cold flow. And ultimately, I absolutely love caring for patients. I also learned a while ago that there are three phases in spine surgeons. And a young surgeon will want to fuse, meaning block everything. The intermediate mid-career surgeon, that I'm not anymore, is you refuse your old scales fusions, so you redo what you've done 10 years earlier. And this is where you refuse to fuse, and this is the motto of this lecture. So the wisdom of trying to not fuse and block everything comes as you mature. So with this lecture, I want to try to critically reappraise some of the major advancements as I see them in this light of these five new big things, and reassess where our true breakthroughs are. I will not bore you with too many, good morning, too many points, but as a business project, the spinal column has all of you guys who do total hips and total knees and shoulder and elbow beaten. I mean, we have, look how many joints we have. I mean, you guys have 4 in hips and knees and 4 in shoulder elbows. Okay, look at all our articulations. And that's, again, plus minus 1 or 2 with dysplasias. But again, we have a motion apparatus par excellence which serves our encephalization. Hashtag here, this is my main mentor. I was very lucky in Texas to fall into the realm of Dr. Dubussy from Paris, a true visionary, not just in spine, but genetics and in oncology. And I was so happy to be with him, and we've remained lifelong friends. He sadly passed away in March of this year. Now, 10,000-foot perspective. In 2011, it is recorded that we did about 200,000 to 300,000 spine fusions in the U.S., and a decade later, it's over 1 million. And those are all best estimates. These are not hard numbers. And one key critical point that'll be part of this lecture is that probably 2/3 or more of these fusions start at L4-5. So this is a really big deal. And again, this is literally from clinic. I'm violating HIPAA. It's a soft violation, moderate violation of HIPAA probably. But this was just in my last clinic. And this is a PT who came to me with 7 spine surgeries from 2016 onwards. My absolute favorite is 4 different discontiguous lumbar fusion systems. Dr. Shen, wonderful, right? I just love that stuff. To the surgeon's credit, maybe also financial benefit, but I'm not being facetious here. These were all done in short stays, so 24 to 48-hour stays, all these surgeries. But his trunk is pockmarked. And this, if you always love doing that, look at the original image that's in our Epic file. This is what he started with in 2018. He had a single level fusion. Doesn't look so bad. And everything else was just a biomechanical check rein of the clash of rigid mechanics versus softening and collagen structure. And again, this is from like 2 months ago. I'm treating a non-surgical. She came to me. This was an MIS masterpiece. I think that this is a good fusion indication. I like aesthetics. I like something that looks harmonious and that I'm really happy about in the end. Yes, X-ray cosmesis matters. I don't futz around. I like it. But this is probably not going to be so great. I don't know. I don't like it. She's very upset. She changed the surgeon right away. We do that sometimes. And I'm following her right now, non-surgical, because everything's actually correctly placed, but it don't look so pretty. So I'm pretty sure this is not going to last. Dr. Lockie, it's going to last 5 years? No. And this is from this spring, and I have not dealt with 4 out of those 5 things, but these are all L4 to S1 fusion disasters that show up in our clinic. Dr. Lockie was there. The top right one we fixed, but the other ones are still kind of brewing around. Questioning spine surgery is a legitimate and recurrent theme, so this comes about every 10 years. And these are recent things. Anybody see these articles or know who the person who writes that is? Jesse, you know that? Yeah, we talked about it last night. So I'm going to send the link to that article on the left to y'all. I think you should all know these kind of popular media type things, but spine surgeries that don't need to happen, very eloquently written by a lady named Paula Aceves, who I don't know who that is. On the right side's a disturbing and a thought-provoking thing by somebody who names himself Dr. Gooby, and I know his name actually. He's going to speak with us at SSF, but this is a young neurosurgeon who has really ethical, you call it crisis of conscience, right, Dr. Lockie, last night over dinner. He has over 1 million followers, and that's really impressive. And he basically is struggling online. He's now living in Alaska. He's struggling online with his conscience of having done too many fusions and not having helped patients. In a nutshell, and I think it's very evocative. It's very problematic. On a big picture perspective, we have obviously the patient in the center, and they're getting torn around between financial incentives for surgeons, hospitals, or hospital systems and industry, and there's obviously the huge financial background of insurance industry, which is doing quite well. A little methodological statement. So the 3 E's of evidentiary economics are, and this is something we always have to remember when we look at literature: efficacy, effectiveness, and efficiency. Those are all 3 different things. Efficacy is when we see PRCTs, which are highly problematic for all of our subspecialties because it is a perfect scenario, perfectly selected patients, highly controlled circumstances. Effectiveness is regular surgeons, real world, and efficiency, how well this economically performs. So for instance, now that you're getting more and more into ambulatory surgery centers, the true efficiency model we put to the test. And this is the problem. 78-year-old nurse, collapsing spine. She's not the fittest person in the world. What will we do? We don't have a lot of time here, but this is, again, this is somebody who came to me, and she had promptly a whatever, L1, I don't know, the top level, to pelvis fusion done. I can't blame the surgeon. She had a combination of stenosis and multi-level lumbar spondylosis, a little bit of slippage is there. But here we now have a problem. She has eroded her dural sac. She has severe stenosis above. She can't function when she's in a wheelchair. And lo and behold, yours truly did a big fusion on her. I can save the world, right? We did a nice job on her, I think. Didn't lose too much. And then Christmas Eve, I'm always on call over Christmas. She comes back. She had a gallbladder surgery done somewhere else. It's like 4 months later. And somehow she dislocated her spine above when they pulled her up on her arms. And she was paraplegic. So they transferred it to us, and we did a repair surgery, which was great. The sad story is that she actually passed away a year after this. She never got better. She was at home, but I think she had GI bleed. And it's just a morbid story. And again, this is what I would qualifies as fusion disease. I say that as a spine surgeon. There's a lot of very major deformity surgeons that do 1 to 3 a week. And this is fusion disease. This patient never really gained from it. So one thing that I put this in as a slide, I want to point out is that in our brain functioning system, neurologically mediated pain really registers very prevalently in our midbrain. So the amygdala and the hippocampus basically are highly sensitized and in fact turning towards neurologic pain. Structural pain, back pain is far secondary to that. So nociceptive input from neural structures gets a primary pathway into our brain. And this is, again, in this particular case, was there something else that could have been done? This is the question again, do we really need to fuse all these patients as we have an aging pyramid of population like myself that will require care? So in spine surgery, this is again a core principle. I think I urge all of the specialties to kind of look at that. There's some core principles, and I think the more you can reduce those down to elemental things, the better, because this is a common ground to talk about. Effective decompression of compromised neural elements is one of ours. Physiologic realignment of the spine as much as possible, and if at all, a mechanically sound either fusion and or reconstruction. So something happened around the 2000s, which basically changed everything. So the days of the old big open spine surgery suddenly became an anathema and was replaced with minimally invasive surgery. There are several people who've done this. Our Korean colleagues, Chol Kim, especially deserves things. My German homebodies, Roger Hart and Krista Hofstetter, they've been very eloquent in this. And this has become like the main thing. There have been whole hospital systems that have advertised that Band-Aid spine surgery. And again, the question is always, is this hucksterism or does this actually serve a very meaningful purpose? And for me, again, if you ask me to build a ship model, I'm going to do it open. I'm going to do my really best job to kind of do a nice ship model. But there are people who are very good at putting pretty decent looking ship models together in a glass bottle. For me, if you ask me to build a ship model, I'm going to do it open and I'm going to do it nice so that it looks really good. And again, I envy those who do it in a glass bottle, but I'm also going to be a little critical how much they actually did this. The common ground for us is, and this is primum nil nocere, which is the Latin transcription of Hippocrates, a statement we should not do harm at very least. And again, this is where I'm really a little bit questioning because, again, we nowadays have these Uzi survivor patients who've been literally riddled with incisions all over. This is, for me, again, aesthetically not pleasing. Going transmuscular and just riddling patients with approaches. When we go from the front of the spine, we scar the retroperitoneum. And if that patient needs another vital surgery, that pathway is not going to be the same anymore. It's doable, but I'm not sure how well this patient was served. Another new term by our good friend Neil Anand, he comes to our SSF things. He calls this the Wolverine stone. This is a very well-regarded MIS surgeon in the LA market. And you can see Juan Uribe from the barrel almost throwing up there because Neil is going to basically say that this kind of stuff where you just riddle a patient with multiple incisions is nonsense. And the term is Wolverine spine. If we look at specifically our retroperitoneum, this is actually a 3D model of our lumbar plexus created by one of our fellows from an actual MRI scan. So you can nowadays 3D print the lumbar plexus. This is pretty complicated. Weaving through that with any anterolateral approach is interesting, it's possible, and if it goes well, it's fantastic. But again, probably 1 in 5 patients have serious neurologic problems, and we all have learned new neurologic conditions like genitofemoral nerve and iliac neuropathies. Professor Shen, these are not things that we were raised with, right? I mean, nowadays we're specialists at pseudo-hernia and stuff like that. So, and again, this is an MIS scoliosis fusion done by a former partner of mine, again, a Wolverine spine par excellence. I think it's a pretty reasonable indication. I did not know of the patient. I became familiar with this patient. The reduction is not perfect. It's doable, but again, this patient was actually in the hospital for quite a while. 16 incisions, I think we counted. But then literally within 2 years, the patient became myelopathic, had fallen apart. The fusion was not there. So while in the short run, you can argue this was actually okay, and this is minimally invasive, sounds so good. This required a very major do-over surgery. So true healing over time and staying balanced is actually a pretty big challenge. And again, that was not reached with this MIS thing. And a single midline incision was used as a salvage. This is just one more case. I put that in yesterday because we had a similar case. This is an executive from a very major software company based in Redmond, Washington. And he's a senior executive. He's had, 4 fusion surgeries by people in the community. These are all MIS fusion surgeries, and they ended up with an L2 to 5 fusion. It was solid, but it was totally off campus. He actually, off kilter. He actually retired from this. We did a single posterior realignment procedure. And again, this shows the power of this eccentric osteotomy. If you look at those center sections in green and red, we can actually, from the back with expandable cages, realign the spine. It's not perfect, but he's extremely happy with this, and I think we did a reasonable job. So you don't have to have absolute perfection, but for him, this fulfilled the goal of a reasonable realignment. So the spine can create a significant burden of disease, and the single biggest problem that we have is that the disease process creeps its way up and down the spine, especially rostrally. And again, we just don't have perfect things about that. We have some new technologies coming out, but for us, this is in our world something that you can fill days, and Professor Chen would have been participant in that. I was at the last SRS meeting, and literally we spent 2 days talking about this junctional collapse, and there's so many factors in this. We now actually think that muscle loss, so sarcopenia, is a really major factor, maybe more so than alignment and all that. Now, switching gears, Professor Lee is working in his great lab on regenerating the discs. And again, this is probably part of the main problem, that our discs, these amazing viscoelastic bioreactors, fail over time. This is a complex physiologic phenomenon. It's multifactorial. Trauma, nutrition, genetics play an interwoven role in this. But what this leads to is this lack of pressurization of that balloon that a nucleus fulfills in our annulus, which is drying up over time, leads to some form of instability. And we as doctors, and this goes, I think, into all of our subspecialties, have not solved a major problem, a major question. That is, what is physiologic aging versus a pathologic condition? And in spine, this is particularly prevalent with all of our motion segments and our discs. And again, physiologic aging versus pathologic condition is just one of those things. Spine is particularly amenable towards the vomit syndrome. Anybody know what the vomit syndrome is? Professor Lee? No? Dr. Lockie? No? You're in Seattle, you're done talk about vomits. Victims of medical imaging technology. This patient may or may not have back pain, probably has back pain, but if this disc means something, we don't know. We honestly don't know that, okay? There's some telltale signs, but what matters so much in our field, maybe more than others, outside of our shoulder-elbow colleagues, is patient factors. The psychosocial factors are a huge deal in our field. And this is, again, where probably AI will come in helpfully. But again, all of you know these situations. All of you know how to ask patients these critical questions, get in a conversation. So back to this patient again. This was, for me, a very sad story because we spent a lot of time and effort on her. She probably should have never had this fusion done in the first place, and we did our best to try to salvage the situation, but can we do something else? So what about the time-honored decompression? So doing a laminectomy or a laminotomy. We now know in my UW days, we did, I think, a very nice study that got a lot of resonance. Mike Lee deserves a lot of credit, but we now know that a full laminectomy, this time-honored laminectomy, which is now 200 years old, is actually very destabilizing. It's over a third of the mechanical integrity of a motion segment gets wasted through a midline laminectomy. If you do a laminotomy, you impair far less, basically half. And this is, again, from two former fellows of mine. They did a very nice assessment. So if you do a full laminectomy, what happens is that in rotation, especially, that's the bottom left graph, the facet joints get really overloaded far more, and then the pars itself gets overloaded. So what happens is you can help patients in the short run, but shortly thereafter, they get facet disease or lateral recess stenosis, and the foraminal disease hits something very vulnerable in the nerves, these big buttonholes in the top right there, the dorsal root ganglia, which are very pressure sensitive. So these patients get chronic pain. Looks great for a year. 2 years down the line, they can get severe leg pain, and then you need to do major fusion surgeries with unclear outcomes. So do we really need to do these laminectomies? Do we need hardware? This is only 6 months, I think, follow-up, but this is a 79-year-old patient done with a standard small midline incisions, an honest 2-hour surgery, 100 cc's blood loss. We did 3 level laminotomies, and you can't beat this. I mean, leave the midline intact, leave the ligaments intact, leave half the joints intact, and do a very nice, clean surgery. This is outpatient surgery. She's completely happy. She, as you can see, is physiologically a pretty large woman. But again, going back towards teaching really good principles of how to do well-performed decompressions is a really big deal. Now here I get into conflict of interest, but I can resolve this for you hopefully right away. We have also ways to kind of give the spine a little bit of stability without hitting it with massive amounts of titanium. So we nowadays have posterior distractive devices that hold the spine in place, and I'm an advisor for this company, so full declaration. But I cannot stand in front of you and tell you which one of those technologies is better. On the right-hand side, you see a spring feather that compresses the spine. So I'm actually advisor for both companies that have competing mechanical influences. I've invested in both companies, so I'm completely conflicted, but I have an internal resolution of left brain and right brain. I've basically, it's like roulette, playing the red and the black field, and you just hope the green doesn't show up. So that's my closest comparison. But again, these devices have for me been a big breakthrough. This is evocative for me because this patient is a farmer. By the way, if you have farmers, I'm sure you have the same thing here in Virginia. They're the best patients in the world, right? And residents of fellows who have a farming background, better hire them right away. Just sold, done. They don't mind getting up at 4 or 3. They can fix anything with a wire or whatever. So this patient had an ugly non-union L4-5 that everybody jumps on that, but she was doing well with this, and she had a big stenosis 2 levels above. We talked about it. She did not want a big fusion. I can't blame her. We did this surgery. She basically walked out of surgery and has been happy, and has been happy since then. And this is, again, just an example for me. X-ray cosmesis would have been nice to fuse at multiple levels, take down that ugly non-union, but that was not her problem. She had no neural compromise there. She had a compromise 2 levels above. We treated that, and so far, so good. This is a case that is particularly compelling to me. This is an 81-year-old active. I am responsible for this fusion below. I think I got about 20 odd degrees of lordosis. This is, by nowadays standards, about 10 degrees short of ideal. She's a former 2-time Olympic medalist. I'm not going to say in winter sports. And she is was the athletic director of one of our major private schools. And she came back to me years later with evidence stenosis 2 levels above. She'd gone to a number of doctors. She's pretty well known. And everybody told her the same thing that I told her. She needs a T10 to pelvis, a T9 to pelvis fusion. She said, absolutely not. And so we did a Coflex device 2 levels above that. She is extremely happy. She's actually 2 years out now. So this is outpatient surgery, just to be sure. Does it look perfect? No. Does it solve the problem of her not having stenosis and not having the spine totally fall apart? Yes. One more, this patient had gone through multiple doctors. She had a degenerative scoliosis. Everybody told her a big fusion. She had an L4-5 high-grade stenosis. Somebody had laminotomized around that. We actually just decompressed her, and I think I have a picture. I didn't show it. Sorry, I didn't show the post-op, but I did a Coflex on that one level, and it's an outpatient surgery. She's extremely happy with that. This is, again, near and dear to my heart. This is actually a former partner of mine. I've done several spine surgeons now, who is very fit, but he had kidney disease. So all of you here, do not take non-steroidals on a routine basis. I know several people now who've had bad kidney failure. So take these with a serious grain of salt, bad pun, but literal pun. Be careful. I mean, he has chronic kidney disease now. Super guy. Disabling mechanism. He had the tubular surgeries and out of state. He lives out of state now. He's of means. And he got worse afterwards. He had a foot drop afterwards. He had this persistent cyst there. And he had stenosis at 2 levels above. On CAT scans, he had this erosive, weird-looking sterile discitis. This still leads us to the fact that there might be some bacterial infection in those, subclinical infection. But again, he was told by several people he needed a fusion surgery. He said, absolutely not. This is a spine surgeon. So we did, again, you guessed it, 2-level Coflex on that bottom level. We did a laminotomy. And he said, I would have not retired if my back had felt like that. So this is a former partner of mine and spine surgeon. So this is a cure. Just want to balance this. This is a stenosis patient, rheumatoid arthritis. We fixed her leg symptoms, but she's unhappy because she has back pain. Am I going to fuse her? Probably not, but I'm treating her non-surgically right now. What is the evidence level? Again, I don't want to overburden with these things, but there have been over 250,000 of those, and I tell patients that about 15% within 5 years actually fail. The vast majority of these comes from the Republic of China, from People's Republic of China. And again, this is way favored over fusion surgeries by the evidence level, which is about half in China. In the People's Republic, this is actually the preferred treatment for degenerative spondylolisthesis now. So this is, again, I just want to balance my statements. This is an 80-year-old radiologist. I did the single-level Coflex on him, and 5 years later, he developed some low back pain. It's still nicely decompressed. He's clearly moving a little bit. I showed him the images. He's a radiologist. And he said he has no neurologic symptoms. He's going to think about it. So he's going to come back in a couple of years. Let me know. So don't know, I can't tell you how long these truly last, but again, I've shown you a couple of cases. In the short run, it certainly looks very good. Now, switching gears towards disc replacement. I talked about the critical part of discs failing over time. Why not replace them? So we actually have the 25th birthday, and we celebrated that in our 7th annual motion preservation course. So 25 years in these shorts, 2000, Scott Blumenthal brought the Charité disc to us, and it was highly, highly controversial. Now, we can think of lumbar disc replacements having failed because the number of implantations has actually decreased. It's actually increasing now again. This is the latest data from 2022 that goes to about 2020. But in fact, cervical discs have percentage-wise, as a percentage expression to fusions, increased substantially. It's again not totally clear, but for me, this is one of those things. I'll just reveal my bias here. If I have a patient with 1 or 2 level symptomatic lumbar disc disease, I will do a disc replacement any day. I'll obviously have a differentiated discussion. I've been extremely happy with this surgery because it is actually, and you'll see some data in a second, long-term big picture data that's actually very compelling. But this can actually serve to interrupt this fusion breakdown. Without going into too much detail, this is the old FDA studies. They show that both fusions and lumbar disc replacements both do well. Neither of them are a cure, but both of them can help patients. This is Rick Geyer, who's, again, the famous Tiger Woods surgeon, showing a 3-level off-label disc replacement. He is a absolutely wonderful mentor of mine and one of my heroes. But these procedures work, as you can see, but if you compare red and, I hope nobody's red, green, color insensitive here, but basically this equipoise or relative equipoise of data has led a lot of surgeons to go like, why would I deal with disc replacements? More difficult to put in, very difficult to get approvals for. Let's just do a good fusion. And I can't totally blame you. But maybe this will change your mind. So this came out in January of 2025 in JBJS, over 2,000 patients, 7 to 21-year follow-up. This is by Thierry Marnet. For those who are interested in our SSF programs, he's actually going to speak tonight. I'll be in the plane, so I'll not host this. I'm sad to miss it, but for anything for UVA. But he's one of my heroes. I've seen him in Montpellier. He basically created this lumbar disc replacement in its current form. And again, these are some of the data points. You can hear him live tonight at 5 p.m. Pacific time, so that's 8 p.m. your time. This is from his JBJS article, and this is, again, high-grade evidence. He lowered, against no cure, but he lowered the odds-associated disability index by 20 to 46 points. 10 is usually the important threshold for efficiency. So this is a substantial improvement, and again, it's been sustained over time. If you're not convinced by this, the top right bar shows percentage improvement. So this is, again, not a cure, but basically a 50-60% improvement is actually very reasonable. And for patients who have a mind that is constructive towards that is good. The most important thing is perhaps compared to fusions, that the revision rate overall, cumulatively in that long time period, is 4.1%. Revisions of the index levels are under 1%. Hip surgeons out there, who's a hip surgeon? I need a hip surgeon. What do you tell patients for total hip replacement? How long does that last nowadays?
0.5% failure per year for the first 20 years.
Perfect. Yeah, and this is and total hip replacements are the operation of the century per Lancet. Hexet's 1983 or something like that. This is in that realm. This is 10, 20 years out. We don't have a synovial joint to contend with. We don't have that significant foreign body wear. And adjacent segment disease is 1.85. In our world, this is really up there. So look at it tonight if you want to. Switching to the neck, again, this is a masterpiece of physiology. All of us hopefully will keep our necks straight. I see somebody rubbing their neck back there. So keeping your head over your shoulders, remember, encephalization, it's absolutely critical. One of the things we talked about last night in a very evocative case of an 83-year-old woman was spinal cord injury. We all know the dramatic, horrible injuries, but this is actually a surreptitious slow injury in its myelopathy form. And this is undertaught in medical school. Who are medical students here? Any medical students here? Please become cognizant about myelopathy. This is not a simple exam, but it's something that can make a huge difference within patients. And it's not well enough taught, at least not at UW. I failed in getting this more implemented. Our spinal cord is fascinating because the viscoelastic structure that has internal tracts that are differently tensioned. So this is an extremely complex integrative neural structure that responds to various compressions from the outside in a differentiated fashion, especially lateral bending with stenosis is very pernicious. Now here again, disc replacement. So this is our good friend Rick Sasso, a close friend of mine. And we have really powerful long-term data. So 20-year outcomes of disc arthroplasty with a device that, by the way, came from Seattle that's no longer available, the Bryant disc, a neurosurgeon from Seattle concocted this. I did two, and I swore to myself back when they came out, I'm never going to do another disc arthroplasty. It was that painful. Francis, have you done Bryant discs?
I'm not.
They're terrible. But he did 20-year follow-up. Rick Sasso is a larger-than-life guy. And again, comparing to fusion, this was a PRCT. The disc replacements and the solid lines did a little bit better than the fusions, but not dramatically. Neck surgery is really beneficial because in all parameters had a substantial improvement over 20 years. Now that's serious data. And being Indiana, they had wonderful follow-up. Now here comes the biggest thing. Reoperation rate with the disc replacement patients was 10%. With fusions was 41%. So the data is really there that disc replacements have a far lower reoperation rate. And this is over 20 years with a mechanically inferior device, the Bryant disc. So switching gears again, the neck. This is something that we see all the time. This is a 67-year-old, very well-to-do man, single, always looking for a new partner. Ataxia, hands feel stiff, no weakness. He does not want to, he has the Peter Pan syndrome. He always looks for partners to hop around the world with. Dull neck pain, had carpal tunnel releases, a very common theme with myelopathy, no relief. Dull neck pain, and he's not doing so well. This is an MRI scan and multi-level disease. Putting you on the spot. Dr. Lee, what do you want to do? Laminoplasty. Do you slow my thumb to Dr. Lockie before Seattle?
Before I came out to
Yeah.
say 3-level ACD.
And nobody could blame you. Dr. Shen?
3-level ICD.
Nobody could blame you. So again, this is perfectly fine. This is, by the way, the patient in that small vignette. He allowed me to show this picture. We did the laminoplasty on him, and he went back. This is the Tower of Macau, the tallest bungee jumping tower in the world. He did this after his laminoplasty. He also has videos online where he flies with these squirrel suits through the valley system in South China. And so this is one of those people he can't get. Laminoplasty is awesome. It's 40 years old now. This is developed in Japan, mainly for a condition called OPLL that is actually probably not suited for it. It has one major problem. There's so many variations to the same technique that's infuriating. I've been to Japan multiple times and actually learned the technique there. And every perfectura has its own variation. It's infuriating when you have this variation. We stumbled upon the laminoplasty thing when we did a very large, expensive, overall 280 patients. This is just a temporary thing with AO Spine North America, myelopathy study for surgical versus non-surgical treatment. And we somehow weirdly stumbled upon that laminoplasty has the same neurologic improvements, but actually far less complications. This is just one of the many vignettes of this macro study that was published in like 10 different publications. But we were all surprised how well laminoplasty did in all regards. Now I'm going to show you something. I'm conflicted here because the journal I get to be co-editor-in-chief of, so I apologize for that, but I found this study to be amazing by Mohammed Sarraj and others. It's from Canada. They're fantastic with their methodology. And they basically looked at ADRs, cervical disc replacements, and laminoplasties, and they had 73,000 patients. And again, I'm showing you one graph out of this. I'm going to magnify this. So first of all, disc replacements versus fusions, the revision rate for disc replacements is in the pink. It's lower than that for fusions, so yet again, more evidence in this regard. But here's the data that really struck me this year. There's one summary survival curve, and that's on the top. It has almost no revisions. That's laminoplasty. So this is pretty amazing to me. Laminoplasties are a non-fusion surgery that globally can decompress the subaxial spine, and it solves the issue pretty much for the duration. Patients can go back to whatever they want to do. Are there complication potentials? Yes. Is it a surgery where you have to be very finicky and precise? Absolutely. But the data is there. And this has, by the way, been borne out in more recent studies also. Zoe Gogavala from Boston, great guy. With Ed Benzo and a number of others, did a equipoise trial, meaning patients that you could, just like right now, what you heard from Dr. Shen versus Dr. Lee. You can go anteriorly, you can go posteriorly. This is an equipoise trial. Just pull this out of one of their various papers. These are, again, landmark papers. This shows the improvement of anterior versus posterior fusions or laminoplasties. I'm going to step over here, or I'm going to see whether I can make the laser pointer work. Maybe, maybe not. I don't want to jinx anything. Or maybe this is. So this line here basically shows patients with improvement. These are anterior surgeries, these are posterior. Anybody who is with a graph going up above this line got better, okay? There's one trial group of patients that, with one exception, had only improvements. This is the only field, but the light blue, you guessed it, was laminoplasty. So literally all the laminoplasty patients, with one exception, got better. There are persistent kind of non-winners in the others. I'm just pointing that out. And again, complications way lower in laminoplasties. By the way, this is a board answer, a board question now. Hint, hint, hint. Somebody wrote that. Dysphagia. It's pronounced dysphagia. This is not dysphagia. Steve knows that. I go nuts with this. Dysphagia is dysarthria, or hoarseness. Dysphagia is the difficulty in swallowing. Anterior surgery is 18%. Laminoplasty, 3% complications. So outcomes, return to work better. Putting it to the point, 60-year-old neurologist. Again, I cannot blame anybody for wanting to do a 3-level fusion on him. He is a chief neurologist in a hospital system in our area. He had a quadriplegia. He's a surfer. He's actually a really cool neurologist. He had a quadriplegia event. He came to me afterwards, and we did a laminoplasty. And this is his outcome score. He's literally back to, you can see the top line there, 0. So going back to disc replacements now, they've been around since 2006 and 7. And again, this is one of the breakthrough technologies I've seen in my life. This is, again, for me, the go-to nowadays for 1 or 2 level disease without a question. This is a 45-year-old female, and basically the patient's returned to normal. Again, critical question, how much better is it than fusions? You've seen some compelling data that shows that in the long run, they do better. This is Jack Ziegler and Scott Blumenthal with Gary, who runs our famous SSF lab. I'm very proud and privileged to get to work with these wonderful people. There are no massive differences of fusions except for range of motion, obviously, and satisfaction. But once we get into 2-level terrain, this is from Reggie Davis, 2 levels, there's a distinct advantage, not just in revision surgeries, but in outcomes of disc replacements versus fusions. Putting it to the test, and with this we'll get to a close of this lecture shortly. There's one exception, 67-year-old pediatric intensivist, again, super fit guy, just one of those wonderful people, severe arm pain, C6 active radiculopathy, C7 weakness, go figure, and he had 2-level, and this is a stupid surgery, anterior uncinectomies done in LA because it was minimally invasive, sold him as MIS. He has funds, he travels, he plays every sport you can imagine. He, again, joins a club of lost boys who can't age. So what do we do here? What do you want to do here, Dr. Shannon? Put you on the spot?
No worries. I did anterior for this one. I don't know the levels. I'd have to check, but some sort of anterior stabilization.
2-level disc replacement. Can't ask for a happier patient. And again, the critical question for us spine nerds is this patient, if you look at the top images, has a kyphotic neck. We use an implant that allows us to lordose the neck, so we actually restore lordosis with a disc replacement. In our world, this is in mobile discs not really possible, but with the right disc and the full release, you can do it. Now, final part of this soliloquy, and I appreciate all of your attention. This is very important. This is gelt, this is money, and this is regulatory problems. We had at our last motion preservation course a fun segment where we all impersonated insurance companies, and we actually replicated and we actually played live, not live, but vocal recordings of some of our appeals. So a lot of insurance companies use in our field every possibility to kind of deny procedures. I don't know whether another specialty has the same struggle as us. And again, the reimbursement angle and the difficulty in getting approvals done is very difficult. Bottom right's, by the way, the famous picture of Hippocrates denying payment for his services by the Persian king at the time. I forgot his name now. It's not Xerxes, but it's a famous thing of denying money. And this is the angle of this. I'm comparing work RVUs. These are calculations for our area and the different interpretations of hospital systems. So just take this with a grain of salt, but the gestalt is completely spot on. We get paid about 20% less for a cervical disc replacement for a fusion, but jumping through the hoops with insurance companies and the precision of decision-making and surgical implementation assume is much higher. This is not a woe is me soliloquy and all that, but again, you get paid way more for a fusion. If you actually put a certain type of cage in, you get paid way, way more. Lumbar disc, same thing. Way higher reimbursement for a fusion compared to a disc replacement. Pre-level disc replacement, Professor Shen's favorite procedure. You make out like a banshee compared to a laminoplasty, which is a very precise surgery. And then here you can hit the home run. You do a 2-level cliff. You see at the bottom, depending on how you code it and what cages you use, you can hit up to about 100 work RVUs. 2-level Coflex 27 and 2-level decompression 22. So to some degree, you got to be a masochist to do these surgeries because our systems, remember that trifecta we talked about, does not reward this. Industry tries to sell you more screws, more hardware. The hospital system. So I am in the leadership role, take that with a serious grain of salt again, in our 42 hospital system in our neurosciences group. In all seriousness, somebody in a recent session told us we should emphasize doing more 1 or 2-level fusions because they pay so well. This is, honest to God, what I heard there from senior administrative leadership one day. Just saying. With this, I conclude. So if we accept the premise that we should not harm patients, I hopefully have made a statement that we can actually help patients substantially with simple quality laminotomies. They're outpatient surgery compliant. You don't need to put tubes in them. You certainly don't need complex endoscopes or robotics, as nice as that is. Interlineal stabilization and whatever mechanical permutation is very compelling. And I think cervical and lumbar disc arthroplasty, for me, are my go-to for these things. And again, look at the bottom left. This is a common scenario for fused spines. It's an annuity principle. So a mobile spine can be a happy one, especially if you've maintained the 3 Rogers principles of good neurologic decompression, reasonable stable alignment, and physiologic overall mechanics. For this, hopefully, you'll see that the true breakthrough for us is motion-preserving surgery and life is motion. Thank you.
Great. This for Dr. Chapman. So one quick thing is important is I find as my practice gets further and further along that I'm not actually operating on spine pathology anymore. I'm just operating on iatrogenic spine pathology. I haven't really, as I get further along, I'm no longer just working on sort of index primary problems. So now, with this being the challenge, I'm trying to find things that allow me to conserve motion, but often my fallback is still to try to get back to stabilizing the spine. So what do we do now as all these residents go on to their practices and they're starting to find that they do more and more revision work and they're starting to treat an iatrogenic disease?
It's a fact of life. Once you're in the mid-level of your spine curve, if you accept that trifecta, becoming a revision surgeon is a fact of life. In arthroplasty, and our hip and knee colleagues, you have whole subspecialties now that do nothing but revision surgeries, right? The common private practice person does not want to do revision surgery, so they come to major academic centers for the most part. I assume that's a reality at UVA, Charlottesville as well. So these are real life factors, and you got to do what's best for a patient. I'm not saying don't do fusions, but under certain circumstances, like in that Olympic athlete, I was able to preserve her motion. She's been very happy. Will she be happy 10 years from now as a 9-year-old if I'm still around? I hope so, but doing surgeries that don't ruin patients for good. Like for me, this one traumatic experience of this patient has been obviously very prevalent in my mind. That this patient did not need a fusion surgery. This patient would have been very well treated with a well-performed laminotomy series or maybe a stabilization. This invoking a fusion on her in her mental state, physical fitness, body habitus was just a setup for failure.
Yeah.
Dr. One. Thanks for the talk, Bruce. Thank you. Spine surgery. Some of the pictures you showed, some of the images you showed me, multi-level disease, and you talked about doing replacements. Is there a role for combining fusion and replacement where you get replacement at some levels, but then still having to fuse some levels because you can't replace all of them?
We do
and
that.
some are bad enough. So
If you want to really get into fights with insurance companies, absolutely. So they bought that everything. I don't know how it is in other specialties, but spine may be a leader. I don't want to sound elitist here in terms of controversial engagements with insurance carriers. But these so-called hybrid things are all off-label. We declare it to patients, we document it. And in their algorithms and their AI algorithms of all the insurance carriers, they basically go like, no, there's no literature evidence of that. There is actually, but that's not up for a rational argument. They just use it as a blocker. So yes, we do hybrids. Yes, for instance, for lumbar disc replacements, I've done those above fusions or below fusions to just break through this fusion cycle. They've held up very well. The
Take
mechanical,
one down. What do you think of fusion?
no, but above or below, for sure. And patients are very happy with that. But yeah, the insurance quagmire is not insignificant. It's unreimbursed, of course. For me, it's a matter of professional pride.
Dr. Lee?
Yeah, I like your talk very much. I try my best to teach my resident how to do the motion preservation surgery. And for the degenerative spondy, I used to do a olive and fusion surgery. And after I do the ULBB, I do cut down my fusion rate about 50%. Sometimes it's very difficult to indicate to do the fusion surgery or to do the decompression surgery. And what's your mind thinking about doing the Coflex or the degenerative spondy? What's your indication?
So I have a separate whole talk about that because L4-5 in our world is so critical in terms of decision-making, that first step. And I have 15 variables, but I've not weighted them. But I think with machine learning, we'll have a aid to help us in our decision-making. So the classic ones are how much translation is there? How bad is the disc looking? How loose are the joints? Patient factors. There are a number of things that come into play. But in principle, if you have a halfway reasonable grade 1 degenerative spondylolisthesis and the patient anatomy is halfway reasonable, I'd always do a Coflex or a Limiflex. I found these to be very reliable. I tell the patient I can do a fusion. In our market now, patients are so heightened in their sensitivity against fusions. They actually prefer non-fusion surgeries. But I would, I've stretched the indication, sorry, I didn't show some of those pictures there, but again, I have a whole talk about this. It is actually 15 points that come together that you kind of run through and you condense down. Is it mechanically feasible? Does the patient have a certain risk tolerance? I've revised, I think, 2 out of 100 plus Coflex patients, so I've been very happy with that.
Any other questions? Maybe we move to the second topic.
Yes.
I'm particularly excited about looking at it.
Excited?
Yes.
So thank you all for your patience. This next one has a spine angle to it, but it is hopefully relevant to all of us and is meant to be thought-provoking. So this is, oops, I need some help getting this up on the screen. For some reason, I booted myself out of the screen. Thank you, Doctor. What did I do wrong? Oh, thank you. So aging, I'm 66 years old. I consider myself healthy as a horse until June of this year, coming back from Brazil. I behaved. I became pretty ill and I went into renal failure, was hospitalized for a week. So I'm just telling you, as medical students, a really interesting experience and experiment is laying just dressed with a hospital gown in a bed, being rolled through a hospital corridor with people looking down at you with a mixture of curiosity, shock, recognition, smiles, whatever. It's a humbling experience, and it's one that again shows that we are all vulnerable and finite, and it can happen out of nowhere. The top left-hand side is bittersweet because it combines Vincent Arlet, who's a well-known professor here, one of my Munich friends, Christoph Siepe, and the late, great Professor Jean Dubussy at one of our spine masters groups. So this group will never be together again like this, certainly, and it shows again our lives are short. Again, this is just looking back. This is an old slide, but this is how we all study things. And I think all of us as surgeons and practitioners will see this to be a reality of life nowadays. And the question is, how do you want to do what you've taught, put that into practice here? So one of the problems in orthopedics and neurosurgery is the length of our training, the selectivity of it, and then the effective window of opportunity. And the critical most question is, who decides when it's over? And I started with the phrase of ars longa vita brevis, but the actual sentence, again, a Latin translation from Hippocrates, who wrote or did not write anything, in fact, this is all attributed to him, was in Greek, is actually way better. Yeah, sorry, I had 6 years of Latin, so put up with me here. Ars longa vita brevis, occasio praeceps, experimentum periculosum, judicium difficile, which means, and I think these words are amazing, skill, craft. You can identify ours not just as art, but skill, craft, lasts, alas, life is short. Opportunities are fleeting, while gaining experience is treacherous, and judiciousness is difficult to attain. For me, these are evocative words. This is the whole lecture, basically. But I have 45 minutes to fill. So, retirement. This is actually a phenomenon that came, as far as we know, in an organized fashion from the Romans, from the Roman army. And they instituted this for deserving legionnaires. They got a parcel of land, they got a small amount of food, and they were given recognition for their length of service. It was usually 30 years. The infamous Cotton Mather, yes, that Cotton Mather basically identified that elderly people should be pleased with retirement. You should be dismissed into. This is about 1720. So I thought this is always a very interesting perspective of the aging people are no longer useful. The good German Otto von Bismarck is credited with having actually been the first to organize retirement and mandate it. So 65 or older will be forced to retire and receive pension. So this is actually a German law that was then widely copied. And then from our own physician ranks, we have the famous Dr. William Osler, who said man's, sorry for the genderism here, best work is done before 40 years old, and by 60 he should retire, 1905. So this is just a little brief history of societal and medical expectations. In their regulatory aspects, so in Germany, I'm actually a U.S. citizen and was born a U.S. citizen in Germany, but there's a mandatory government retirement age for all public jobs at 65. So you have to be out. And you can be forced into early retirement at age 60. And recertification procedures have become more and more onerous, and hospital policies are very varied. As a world, we're aging, and some societies are aging far more than others. And it's a well-known fact that you'll all see in every one of your clinics that the next 80-year-old you see maybe actually doing this, I just pilfered this off the internet, be doing stretches and is going to travel some remote parts of the world, while 60-year-old on the left is teeter-tottering around, is going to fall over with the next wind blow. So the aging world's a phenomenon, and chronologic age and biologic age are no longer synchronous. And again, we have, I'm not making any political statements with this on the right side. These are just literally people that are in the public knowledge of. One of them is actually a friend of mine, Hans-Jörg Wies. He's now 90 to celebrate his 90th birthday. He bought Chelsea as a co-owner at the soccer club in London as an 89-year-old. So just saying, we are different in our aging. I'll never forget, as a young man, I was privileged to hear the great Vladimir Horowitz by memory play the Brahms piano concerto in Vienna, and this is actually amazing to see. He had no cards, and he, in an interview later, said, had I not had alcohol, I could have played until 100. So being cerebrally active helps. From a global burden of disease thing, yes, it's a Seattle creation, thanks to the Bill and Melinda Gates Foundation, now known as the Gates Foundation. Musculoskeletal medicine, spine, etc., are major winners. So congratulations on your choice of musculoskeletal medicine, even if you're not a spine surgeon, because this is highly future-proof. And just look at the falls. This is now the second leading cause of death in America. But back to the topic. I digress. So there is a credible fear that, for instance, for spine surgeon, I have seen similar data in an AOA publication, I did not put that in here, that we're actually going to have an undersupply of surgeons relative to our population needs, which is an aging population, which will have more and more musculoskeletal problems. So neurosurgery and orthopedics have done a good job, even though DO programs are now on the rise, and curtailing the number of graduates per year. The actual surgeon lifespan has decreased a little bit. And in neurosurgery, this is AANS data, the pool of over 40-year-old surgeons by far eclipses that of the younger surgeons up to 40. So there are significant issues in terms of a likely imbalance of population needs and actual surgeons available. Now, just a couple of things I'm going to go through the same kind of a graphs and a number of permutations. There are obviously some ranges as to when people get into and enter certain stages of their careers. You can see it here on the right. I don't have to read that out. But somewhere in the mid-30s, people will have concluded, early 30s to mid-30s, will have concluded their residencies and fellowships, and again, board certification. The effective region of life is basically then something pretty late. Now, looking at societal costs, so these are actually expenses that are not borne out by individuals, are substantial in terms of college, medical school, and residency. And this is against societal costs also. And even for billing fellows, there's still a societal cost indirectly through Medicare reimbursement. So the point of this is that the critical time of our lifespan is more or less somewhere between early 30s and somewhere into the 60s or 70s, depending on society and internal well-being, which leads us to conclude that there's about a 20 to 30 year lifespan of us as active, productive surgeons. And again, if you put this expense slide into this, this basically means that if we have a 15-year actual surgical time span, the cost for us is somewhere around $3 million. So this is pretty substantial. And again, so there's a cost of education that we've put into our career development, and you can literally annualize this as a return of investment. Now, looking at it from a different angle, there is a wisdom, and I'm saying that as a 66-year-old surgeon, there's some wisdom in being a little bit more senior. So when I get asked by our fellows and residents, how long does it take me to build a practice, I'll tell them it'll take 5 years until you have a solid footing in terms of being a confident, safe practitioner with wisdom. You don't want to jump in guns blazing. You don't want to fuse everybody. You want to be very thoughtful. It takes about 5 years to get recognized in your community, but also having a solid career path. So that's the timeline. And again, this again bites into that 15 to 25 year effective practice range. Now, this is a highly subjective thing, but I actually used some biometric data for this graph. So if you look at our age span with these blue things and compare physical health, strength, knowledge, and experience with one another, the physical health part declines. I'm a living example, survived renal failure from age 60 onwards. For some reason, things start failing somewhere. Strength part, again, we max out clearly by 20s and 30s, and then it goes down. The knowledge sphere, again, just neurocognitively starts declining by age 60, and the experience level, however, can make up for that, and I kind of drop that off at around 70. So those are the things that I've done a best effort with kind of putting some biometric data together from various sources, but this is, again, a subjective graphing, as you can see by the wiggle hand, and not totally scientifically put together. This is a case, this is not from too long ago, this is from spring. This is a pretty ugly scoliosis. Did our usual spanning rods, working rods. This is about a 10-hour surgery. This is not a little walk in the park. And we had 2.0 liters blood loss, something like that, no complications. Actually, just a 5-day hospital stay with a very good output. The point is not to brag, but when should or when can a surgeon, how long can a surgeon do this kind of a procedure? How long should they do something like this? Should this be done, this mixture of experience, routine, being very efficient in certain things versus other factors? This is a very significant problem to resolve. The threats you all know. So we have musculoskeletal problems, arthropathies. I could put statistic slides on there, but especially in orthopedics, rotator cuff injuries, compression neuropathies are very common. So we talked about that last night over dinner. I urge all of you to become as ambidextrous as you can be. Metabolic diseases are common. Again, just being aware of A1C. This should be in your lingua franca with every patient. We should be the purveyors of this, not primary care doctors. They don't do it. Stroke is a real factor. And again, then we have the neurodegenerative diseases, so myelopathy, Parkinson's, dementia, and Alzheimer's. And all those yellow ones are likely hard stops for surgeons. So once these appear, that's the end. And I've had a terrible ability to pick up Parkinson's in people, and that includes several colleagues. And I, as a chair, had to have very difficult discussions with several colleagues where I diagnosed them with Parkinson's. It was confirmed later, and we had to then talk about stopping the surgeon's career. So these are real factors. Now, the untold other thing that we don't speak about are, as professionals, is mental health. The three factors of depression, burnout, and suicide. The numbers are shocking. There's a gender disparity. It seems to be, at this point in time, more prevalent, at least in the officially diagnosed numbers, between female surgeons and male surgeons. But I'm not sure that this is durable. This may just be a difference in terms of sensitivity of data gathering. But it can happen up to 85% of patients. So this is nothing to be shy about. This is, in fact, something that hits us all, one majority of another. And we do have about 400 suicides a year in orthopedics, as an orthopedic number. There are multiple factors that go into this, and we clearly are in an age of depersonalized care delivery models. We have been relegated to FTEs. There is an overload of work expectation in terms of unreimbursed, unrecognized work, getting your charts done, chart completions. Every one of us, I think, does middle of the night charting. And there's a contentious, ineffective, and litigious work atmosphere. I'm going to share something from our spine section in neurosurgery. And there can be a lack of fun and camaraderie. I don't sense that here, but this is something I sense a lot. And there are significant societal differences. Having a healthy healthcare system is good. So the spine section has put these things together. They have this informal work group. It's kind of fun. This is totally unscientific. But these are some of the reflections. I'm going to use this as a talking point. So we fix fractures, tumors, aneurysms, but not our own burnout. This is, I think, just a very, very evocative statement. Now, this is so true. Fast hands, slow systems. Surgery takes 3 hours. The bureaucracy is easy twice that. And that's a fact of life nowadays. We have to just realize that. This is part of it. Another thing is how unyielding the bureaucracy is. I'm sure all of you have been paged at 5:30 because a consent for a patient that you knew you did and that was scanned into the record is not there for the pre-op nurse, right? I mean, this is just, we insist on patient safety, but basically we get paged forever if somebody somewhere discovers that something is not where it's supposed to be in the record. Then the illusion of control. We train, we plan for everything. And everything goes well until biology happens, something biologically, whether it's DNA-based or fate-based, something intervenes. We have an illusion of control, and it should be control. We're expected to be the calm people in the room when everything goes down, and we can't show nerves. But we have to show nerves somewhere, but it can't be at that setting. So I'm going to get to the point here. The paradox of success, if everything goes well, is routine. I'm sure all of you debrief with a nurse and go like, everything was expected? Yes. You actually did magic. You did a miracle. You did something wonderful there. You did something special. It's routine. But if something goes sour, it's your fault. The ABCs and DEs of neurosurgery, you know that all, right? Accuse, blame, criticize. You have that, right? D is deny. Okay. Perfection is expected. Humanity is optional. So one tremor, one delay, your worth gets questioned, not your workload. And again, we study anatomy, but we ignore our own physiology. That goes back to the burnout thing. Dehydration, hungriness, sleep deprivation, we push through as if we're not humans. Then this is something that's really problematic as we work in large healthcare systems. I'm certainly not a very large one. Teamwork with hierarchy. We call it collaboration. We're asked to collaborate, but we're asked to not speak up if there's system problems. And this is ethically very challenging. And then finally, for teaching institutions, I thought this was a good one to pull out of this collection of statements. We're expected to train the next generation between emergencies, calls, and exhaustion. I do think that this is a particular calling and a particularly cool thing to be allowed. And just like myself speaking to y'all, so I appreciate that opportunity very much to be allowed to influence the next generation. Yes, they'll take care of me also. I want somebody to do a really nice decompression of my stenosis one day and not fuse me necessarily. But this is also difficult because this takes place under a lot of additional strain, and it's not recognized, and it's certainly not recognized by most healthcare systems. So what are the answers? There's not a single answer, but talking about it helps greatly. Talking about it in confidence helps. Talking about it amongst one another, having safe spaces where you can talk. What really, for me, has been the main thing is trying to really be proud of your skills, keeping your skills up, the humanity of our work, and then having the ability to have, give, and receive mentorship. It's an active, interactive process. I learn from my fellows, I learn from our trainees as much as from anybody. I learn from my scribes. So I think this is the kind of a trifecta of things that basically are the counter things, and recognizing what's going on, adding to this lexicon of problems. Now, this gets into a very difficult subject, and that's physician competence. This, again, ties into aging. I assume everybody in this room knows of Dr. Death, right? Everybody who's heard the podcast, show of hands. Who's seen the TV show with Alex Baldwin? Only one or two, wow. It's terrible. So Dr. Dunch was a neurosurgery resident at the University of Tennessee. There are there are actually several friends of mine who are involved in the training. And this is a real problem because we have system problems here. There are strong thoughts that Dr. Dunch never did a lot of cases. Documented, I think, is about 180 cases through 8 years of neurosurgery. That's an accomplishment, if these numbers are true. There were no consequences to evident ill conduct early on. And then interdisciplinary reporting or interinstitutional reporting is very problematic because everybody's walled off, everybody's worried about litigation. And that's, again, a fundamental problem. And then, and towards the problem in Texas, because I still have a Texas license, I love Texas, but they have a cap limit there, a tort limit, I think it's $800,000 for pain and suffering. So this was used, by the way, by the litigation industry. So the Hollywood show was actually paid for in part by the American Trial Attorneys Association because they wanted to change the perception of Texas litigation. They wanted to open up or take away the tort limitation. They said that the tort limitations are the problem here. I'm not sure about that. So he's in jail for life. Undeniable, and this goes to all of us, is that there was substantial chronic substance abuse with uppers and downers. There were multiple instances of documented acute intoxication, and there was a highly dysregulated lifestyle. So these are all factors that can be stated in public, and this goes to all of us. So as a surgeon, you're a high-performance athlete. You have to really take care of yourself. If you regularly need uppers or downers, rethink what you're doing. Acute intoxication and work is just not okay. Never was okay, but nowadays exceptionally poorly tolerated. And if you don't have your regular sleep and wake cycle, you got to somehow revisit how you do things and what you do. The good news is all these three things, if you don't do those, you actually have a very nice, long life ahead of you. Should we do driving tests for aging surgeons, regular driving tests? Well, that's still not clear. And again, there's this growing body of ageism. And I'll give you some examples of heroes of mine. I want to warn you, they're all neurosurgeons, but this is a really big deal. Who and how gets to decide, or proctor, all politics aside, what's going on. The self-test that all of us can do as some of you younger people go into medicine is what makes you pursue this? Is it money, power, prestige? Is it fun, passion, or community need? And again, if you're in it for money or power, you're probably in the wrong field. Prestige, same thing. Prestige is eminently fleeting. Fun and passion, strong, yes, and community need, huge, yes. So these are just some longevity thoughts in terms of your internal motivation. And apply positive psychology. Positive psychology is so much harder to practice than negative psychology. All of you know that. If you have if it takes 7 positive psychological inputs to counterweight 1 negative psychological input. You all know the statistics. I think it's what my wife's a psychologist, 1 in 8 or 1 in 7, something like that. But it's a reverse problem. The balance is really inverse. So applying positive psychology. Do you like your job? How well do you like your job? Having professional friendships like here is huge. Self-care, it's simple. It's all there. Listen to Dr. Gooby. Exercise, nutrition, avoidance of toxins, understanding toxins, and not being shy of being open about it, seeking counseling. Focus on future projects. Always have something. What are you going to do next? And being adaptive to new technologies. I just outed myself. I'm trained in endoscopy. I will not do it for a patient because I think it's absolute nonsense. But I in our SSF lab, live in heaven. I get to do all these things and try to be totally up on them. And having a happy home life, man, that's a huge deal. So here's some heroes of mine. John Jane Sr., UVA, longtime chair. He died in '83. He was a very big influence because he was at UW a lot, multiple of the faculty. He had like the biggest chain of chairs in North America. He practiced until 75 years old. He's the editor of Neurosurgeon until age 80. He developed the GBM, ironically, and died from that. But an absolutely magnificent person. He loved what he was doing. And until the end, he traveled out to Seattle just like 3 months before his death and spent a week with us again. This is another here of mine, Majid Sami in Hanover. Yes, he works in the brain hospital in Hanover, Germany. You can see it on the highway if you go by there. He's a skull-based surgeon. He's a hospital owner. He now developed a new hospital, imitation of this in Tehran and one in Beijing. So he's 87 now. He still does skull-based surgery. I recommend, even if you have no interest in neurosurgery and being in his OR, it is calm, it is beautiful, it is collected. There's no stress, there's no screaming, everything flows. And again, he has no jitters. He takes care of himself. He drinks a glass of wine maybe once or twice a week. This is Persian tea, by the way, on the bottom. He serves it himself. He's a master of humility. And sorry, warning, another neurosurgeon, a good friend of ours, Henry Marsh. He was the former, what we would call chair of St. George's in London. And he wrote 3 bestsellers. Anybody ever hear of those? Do No Harm, Admissions, and Then Finally? No? So I give those to our fellows. The Do No Harm was actually a bestseller. And it's a frank discussion about complications and how fragile life is and how gratifying it can be. And finally, it's very bittersweet because he has bad metastatic prostate cancer now. The middle book was about his fight with the NHS, which he, of course, lost. And having the individual form of power of a chair just basically being subsumated by systemic medicine. But I find these very inspirational reads. We had a program with him last year, was a lot of fun. It's also very mind-opening in terms of he worked for many years in Nepal and in the Ukraine prior to the Russian invasion. And he actually has a very differentiated view on the value of that. It's not necessarily positive. It's a more nuanced kind of a reflection. But he always has something to do, and we're going to do another program with him next year. So self-reflections are, why am I really doing this job? Can I establish healthy work-life boundaries? What are my main obstacles to my professional unhappiness? Don't say administration. That's a given. How profound are these obstacles really? And can I overcome these? No, you can't overcome administration, but existing with them and being influential with them hopefully works a bit. And how well am I actually doing in the OR? Refocus your practice. If you notice that there are certain things that don't make you happy, don't do them. So the greatest threats to surgeon wellness are burnout. If you do everything right, you can probably add 10 to 20 years to your surgeon lifetime. I gave that gap of about 25, that delta of 25 to 30 years practice. You can probably add 10 to 20 years, as I showed in these examples to it. There are regulatory realities. One of the best tumor surgeons in the world is Stefano Boriani. You know him. He was at the University of Bologna. A prince, I should put him in as an orthopedic example, a prince of a person. A phenomenal game changer for orthopedic oncology care and spine oncology. A magnificent surgeon. I saw him operate. It's just amazing. But it takes a day for a surgeon, but it's beautifully done. We had him with us for 2 weeks, and he's just an amazing teacher. At age 65, the Italian government, mandatory retirement, basically threw him out. He was way too young and way too good of a shape. He always took great care of himself. So he went to Bologna. He's in private practice there, and they're mad at him because he only does about 2 or 3 degenerative spondy fusions a day. They want him to do like 5 or 10. It's a true story. And he's very frustrated with that, but he's trying to live with this. The greatest threats to all of us are the infamous burnout, depression, yes, suicide is real, and neurodegenerative diseases. The upside, again, if foundations are done right, is experience, wisdom, efficiency, and some degree of authority, especially in negotiations with the administration, are really big deals. So these are the caveats, the goods and the bads. Enjoy it while you can and make the most of it. And I'll end with what I said earlier. The skill and craft lasts. Alas, life is short. Opportunities are fleeting, while gaining experience is treacherous, and judiciousness is difficult to attain. With that, I close. Thank you.
Thoughts, reflections? That's a really good talk because I think all of us struggle with this at different stages in our life, and it's like, I'm in my fifties now, we're talking about that, I'm starting thinking about it. The thing you mentioned near the end, which is really out of our control, and you said it's the administration, and maybe it's not even that, it's the sort of technology that's imposed on us with documentation, things like that. I find closer as I get that, I understand now when I was younger, surgeons who could still practice would suddenly retire, and it was not because they didn't want to take care of patients anymore, continue to operate. They just say, there's just too many things being imposed on me. I think it's time for me to sort of move on. So I didn't really understand that as much. I'm starting to feel some of that nowadays. So the question is, how do we sort of protect ourselves or manage it on the front end while we're still young and can see it happening or don't see it happening?
So I actually learn a lot from younger colleagues all the time. My biggest regret is that I never learned proper typing. I'm still one of those hack typers. And I have scribes in my clinics. I don't want our fellows to have to type notes. And I'm just marveling at how they can look around, watch me do things, and just fly with their hands. And it's amazing. Yes, I have to revise it, and I take way longer for my revisions. But I learned from younger colleagues how they are strategic with Epic in our scenario, how they collate certain tasks so that you can do them as fast as possible. And being very efficient with that so that you have a compartmental so that you're not at 11 o'clock trying to close charts to meet some deadlines. This is a huge deal. So the more organized we are, the more we learn from younger, very IT savvy colleagues how to be super efficient with these onerous, merciless tasks out of the way, the better.
90% of what's going to hit all of us, we don't even see coming. We don't even know what it is yet in 5 years because it hasn't been brought to us. And so that's the hardest. So it's really trying to build these systems with each one of us that we have a team, but it's just hard because we don't even know what it is that's going to do in.
So the infamous answer to this is AI right now. And I actually see, and we're living in AI wars, AI is here. So the insurance companies that I've complained about use AI algorithms to kind of deny our cases. We use AI in our system to kind of predict that. So whenever we get something, we actually put that in and we then adapt our phrases. So we have little catch questions to predict what they're going to complain about. And so there's an AI war, but I have now started using Copilot. So an ambient kind of it's half machine learning, half generative language model that basically tries to extract notes. This is going to be a 6-month learning time, but I actually think that this will take away a lot of our documentation needs. So I do think that AI will help us overcome the regulatory burdens of documentation and ease a little bit of that. That's my hope. But again, it's an ongoing battle because insurance companies use it also.
Dr. Weiss.
Thanks for the talk, very informative. Similar lifespan, lifestyle, lifespan, I guess, to Dr. Schatz as far as thinking about aging and thinking about things. How do you, as chair or as the leader in your group, evaluate aging surgeons? Do you guys have a program for any sort of a formal thing? There's been some discussions over time about formal things or about certain somewhat arbitrary time frame, 65, 70, and certain, just like a driving in some states after 70, you have to take a test every year or something like that. But it always seems to be there's going to be this big mix of people. Some people at 75 or 80 are going to pass the test that a 60-year-old, that operate at the level of 60-year-old, whereas other people in the 60s or 70s, even if taking care of themselves, may not be in good shape for various reasons that you stated. So how do you keep an eye on
There's no formal program for that. Honestly, this is peer review, being close to your group and accepting criticism and feedback. And again, having a healthy QI system for many reasons is important. But when there's certain things that start popping up, that is an issue. I remember very tragic, I'm not going to mention the names for obvious reasons, but in my UW days, I had very difficult discussions with colleagues where there were tremors, there was rigidity starting, and that's a real problem. On a formal basis, again, we have to recertify. The recertifications become more and more onerous as you age for whatever reasons. Going through those questionnaires and that recertification program is actually surprisingly difficult as you age. This becomes more and more of an imposition, but that's not a protection for society. Again, I can't tell you what Majid Sami did in Hanover, Germany. If you saw him in the OR, I think everyone in this room would say this guy has every right in the world to keep going. There's not a single red flag in how he performs his surgeries, how he talks, how he thinks. Again, we're very different in that regard. And this is an extremely sensitive, very problematic thing, because then at the same token, you have a Stefano Moriani, who was literally thrown out and leads a life of pretty big misery now in Milano. And you have people in their 50s who should probably not be doing what they're doing, who don't take care of themselves or are cursed with a bad genetic or disease constellation. So this is the only answer I can give you is having an honest, like, faculty feedback, having close friends around who are willing to tell you the truth and probe you and ask you, is this what you really want to do? Does it make you happy? What's the drive here?
I think it's hard because I think, we don't, we have a very collegial group here, but we don't really observe each other in the OR. Like, I don't operate with other surgeons regularly. I'm maybe around them. I pop into the room, say hi, talk to them for a few minutes, but we're not like, you don't have a colleague with you watching your moves. You see it in potentially in Q&A or morbidity mortality type stuff, but those are fairly blunt instruments. They're not very fine tuned. So I guess it is more like the day-to-day interactions or the.
I think you have actually the most powerful feedback loop in the world. You have trainees, you have residents and fellows and medical students. They have eyes, they have ears, they see how things are done, and they're very honest observers. They may not know the nuances of why this aneurysm was more fragile than that one, or why this hip dislocated versus that one didn't. But in the big picture, they are very honest observers. And I find that actually a very helpful thing. And it's fun, it's a challenge, it's your mirror. How am I doing compared to my fellows? And how am I being received by them? So if people don't want to work with you anymore, or internally there should be reporting mechanisms of concerns. That's the famous medical school questions. I still prep from medical school. All my scribes want to go to medical school. The famous ethics questions. You're a medical student, you're an OR. There's alcohol on breath of the attending. What do you do? It's a nighttime case. How do you handle that? So the trainees are actually probably the single best thing. The nurses are also very, very observant of that. The best thing is in your own practice as a spine surgeon, if the OR staff all comes to you for your care, including surgery, you're probably doing something right. But that's very safe. But I think trainees are probably the single biggest, honest body of observers. Their feedback is gold.
Questions?
I didn't put anybody to sleep, so I appreciate it.
No, this is great. Well, we really appreciate you coming. This has been a great opportunity for us and me personally, as well as followed you for decades before and been a friend and a mentor. Just a little something from the Department of Orthopedics, a lot of March for Cavalier Orange, as you know.
Cavalier Orange.
Yeah, so I'm just a little of our